Next on the list is Mrs. Burton, who's in the MICU.
All right. Well, how's she doing?
Well, her acute kidney injury is not resolving.
All right. What are the plans for her today?
Just to summarize her, she's a stage 4 chronic kidney disease patient who came in status post-trauma in the ICU, and we were consulted for acute kidney injury on top of a CKD.
Okay.
The plan for her today is that because of her fluid requirements, her triple lumen catheter will be removed, and the ICU team are actually planning to place a PICC line.
They are.
Yes, ma'am.
All right. Why specifically a PICC line? And where are they going to place that PICC line?
So they're going to place the PICC line in her non-dominant arm, which is her left arm, and they're doing it because from their standpoint, it's much easier and convenient to do blood draws on her because she's a vasculopath, and it provides the outside facility when she'll be discharged to do blood draws daily without having needle sticks on the patient.
The nurse said that she's a difficult stick.
All right. Tell me a little bit more. Does she have, if I recall correctly, she has had or still does have an IV in the other arm too?
Yes, ma'am, she does.
So she's going to have a PICC line in one arm, and they have accessed the other arm multiple times with IVs, etc. I'm worried about that. Does anyone know why I'm worried about that?
I'm not
that
sure.
PICC line?
I'm not sure.
Okay. Well, this is did you say stage 4?
Stage 4.
Stage 4. And this woman has had a critical illness. She is now nearing stage 5, needing dialysis.
Right.
What do you think her chances are of needing dialysis when she leaves the hospital?
Very high.
Very high.
She's heading towards it, yeah.
Okay. All right. I agree. She's already at stage 4. We know one of the biggest risks for progression to end-stage renal disease is the GFR, where she is right now.
Mm-hmm.
The other risk would be proteinuria. That would be another determinant of whether or not someone who goes into acute kidney injury is going to recover. So how can we help her to be successful as a dialysis patient? What is probably the most important predictor of survival and staying out of the hospital when somebody comes to dialysis?
To have an AV fistula.
You are right on. Absolutely. We know AV fistula decreases hospitalizations, increases survival, prevents inadequate dialysis, and certainly prevents infections. Now, that's the problem with the PICC line. The PICC line, because it's a subclavian access, even though it's tunneled all the way up the arm, by having any sort of subclavian access, we know that it causes stenosis and or thrombosis. And in fact, studies have shown that if you have any kind of line in the subclavian vein, you have between 46 and 100% chance of stenosis. And it does not depend on how long the catheter's been there, the size of the catheter, or the demographics, specifically age of the patient. So if they're going to put a PICC line in her non-dominant arm, that means both arms have been, or both venous systems of the arms have been violated. The punctures, venous punctures, also causes scarring and thrombosis, but at least it's not the subclavian. Are there any alternatives to putting a PICC line in that non-dominant arm? Anybody know of any? A couple years ago, there weren't good alternatives, but now there is. They can actually put in a small bore IJ tunneled catheter in order to allow this patient decrease sticks, allow them to have long-term antibiotics, and they don't need to in any way access or puncture the subclavian vein.
I see.
So for this woman, in order to set her up for success, it would be best to save one arm. And
The non-dominant left arm would be the best one.
you've got it. Now we will allow them, to put an IV in the dorsum of that hand, but if we really need to talk to the critical care service about not putting a PICC in that non-dominant arm and saving that in order to help her be successful in the future.
Sure.
One of the biggest determinants of whether or not somebody has a functioning AV fistula or not is whether or not they've had a PICC line. And in fact, we know that it is the number one cause or determinant of not having a functioning AV fistula a year into dialysis.
So, Dr. Williams, in this scenario, for this patient, we were lucky enough to be on board because she had acute kidney injury. Most of the times, we are not even on board, and if such a patient comes into the hospital and through the ICU they end up getting a PICC line, what are the chances then?
Oh,
How
really
do we
good
stop
question.
it from?
When we think about system and processes, how do we make this process safer for the patient? The safest way would be if somebody puts an order in for a PICC line, that there would be a flag to come up, so no matter who orders it, a flag would come up saying, you have to talk to a nephrologist. That would be the safest. We need to talk to the ICUs and the floor services about a way that we can change the process of placing PICCs in any patient so that nephrology would be involved when need be. The recommendations from the ASN is that if somebody has stage 3 to 5 chronic kidney disease, and if they need a PICC line or someone's thinking about placing a PICC line, then a nephrologist is involved in the decision making. And I think that should be the recommendation here in the hospital.
And the best way would be to involve the nurses as well in this process. So
Absolutely.
that they're well informed.
The nurses at the bedside can be the best guardians for that non-dominant vascular system.
I was wondering if it would be appropriate to add the level of GFR when we're talking about placing a PICC line, just for the same purposes.
I think that's a good idea, and in fact, some people may be confused about CKD or chronic kidney disease, stage 3, stage 4, what does this mean? In reality, you could translate it to saying in a younger patient, specifically a pediatric patient, a GFR of less than 60 should have a nephrology review because they have a long life ahead of them. And their chances of progressing to end-stage renal disease, depending on their underlying disease, would be great. In an adult, we could say a GFR of less than 45. Certainly less than 30, but I would say less than 35 based on the recommendations from the ASN. The other thing that needs to be discussed is what are the chances of that patient progressing to end-stage renal disease versus dying. And if Mrs. Burton's chances of dying are very great, then it will be fine to have a PICC line because she won't make it to chronic dialysis. But that needs to be part of the decision making between the teams.
And even the interventional radiologists should be made aware because most of the times they are the ones who are doing the procedure, so even they can put up a...
Absolutely. Very good point, that multiple stops along the way. So when the order's put in, have a flag. When it gets to the next step, make sure that part of their process or maybe their pause before their procedure, they look to see, has this been reviewed by a nephrologist?
So hospital-wide education basically on this subject needs to be done.
Not just hospital-wide, but patients need to be,
Made
and their
aware.
families, right? Because those that are in a chronic kidney disease program and are trying to preserve their renal function, part of that education should be save your non-dominant arm, save your non-dominant arm, save your non-dominant arm. Good discussion.
Thank you.
Thank you.